Good morning and welcome to the 22nd meeting of the Public Audit and Post-Legislative Scrutiny Committee in 2020. Can I welcome Edward Mountain, who is attending for agenda item 2. Before we begin, can I remind members, witnesses and staff present that social distancing measures are in place in committee rooms and across the Holyrood campus. I ask that all take care to observe these measures over the course of this morning's business, including when exiting and entering the committee room. Can I also remind members not to touch the microphones or consoles during this meeting. Agenda item 1 is a decision on taking business in private. Do any members object to taking item 3 in private? If those members who are joining us remotely object, please raise your hand. If not, that item is agreed. Agenda item 2 is the Section 22 report, the 2018-19 audit of NHS Scotland. Can I welcome our witnesses to the meeting today who are all participating remotely? Pam Dudek, Chief Executive, and Professor Boyd Robertson, Chair from NHS Highland, and John Conahan, Chief Executive of NHS Scotland, and Richard McCallum, Interim Director of Health, Finance and Governance from the Scottish Government. Can I invite Professor Boyd Robertson, the Chair of NHS Highland, to make an opening statement?
Good morning. I'd like to thank the committee for the invitation to attend today to discuss the NHS Highland 2018-19 annual accounts and the Section 22 report. My role as interim chair of the board started on the 1st of March last year, and Pam only took up post as CEO at the beginning of this week. Our knowledge of the period in question is therefore somewhat limited. However, I am sure that we can provide the committee with an assurance that the report are based and that significant improvements have already been made. I would like to acknowledge here the extraordinary efforts of our health and care teams, our managers, our patients and our council colleagues for the way they have handled the response to the COVID-19 pandemic. Although we're still very much in the throes of this crisis, the response from our teams has been remarkable. To place on record my sincere thanks and admiration for the work. Since my appointment last year, the organisation has made notable progress in addressing two of the major challenges that confronted us during 2019-20. The first of these was the Sturrock report, published in May 2019. That was a troubling and defining moment for NHS Highland in highlighting long-standing issues of bullying and harassment, which had a significant impact on current and former employees. The findings of the report were sobering for the board and for our staff. They were also alarming for our patients and communities. Many positive actions have been taken to improve the culture of the organisation in the past year, including the establishment of a culture programme board, the appointment of an independent external advisor, staff engagement and staff training events, and the establishment of new employee services. One of the most significant initiatives has been the healing process, which was co-produced by whistleblowers, staff side and our HR team. The second major challenge we faced was our financial performance, which led to NHS Highland being escalated in 2018 to level 4 of the Scottish Government's performance escalation framework, partly as a result of a significant accumulated financial deficit, resulting in the need for financial from Scottish Government. Significant progress has been made in tackling that deficit. A programme management office has been embedded to direct and to drive cost improvement opportunities, and a number of revised financial governance arrangements have been put in place. By the end of the financial year 1920, we had fully achieved our substantial savings target, with a significant amount being made on a recurrent basis. Year-end outturn exceeded our financial plan. Requirement was lower than the approved target. This has been a tremendous achievement and as a result of a huge amount of hard work by our clinical and management teams and by our programme management office, initially supported by external consultants. There is much more to do in order to achieve financial balance, and of course, this has been affected by the impact of the pandemic. Much of our progress is like 1920 external audit report, which will be published in due course. Pam and I will be happy to answer your questions.
Thank you so much, Professor Robertson. And I now invite John Conahan, the Chief Executive of NHS Scotland, to make an opening statement.
Thank you very much. I will be very brief in the interests of maximising the time available for questions. I'd like to make 4 points, but before I do so, could I just echo the thanks to the staff of NHS Highland, both in health and social care, in terms of the work that they are doing as covered by Boyd. So 4 brief points. First of all, we do see signs of progress both financially and in performance, though there is much more still to do. Second point is I am delighted to see the emergence of a very strong team in NHS Highland achieved through open competition. Thirdly, I do acknowledge that progress has been made on establishing a sound base of new policies and a demonstrable set of practical actions to tackle culture and engagement issues. And lastly, just to note that SG has been supportive and will continue to be supportive in relation to Highland in terms of supplying both external and SG advice on finance, clinical services, human resources and transformational support. Thank you.
Mr. Conahan, before we kick off and talk in more detail about what was in the Audit Scotland report, I want to just ask a more topical issue around the COVID response and any reflections from a leadership governance perspective from NHS Highland. And within that, just to have an opportunity for Professor Robertson, Pam Dudek, and perhaps yourself as well, Mr. Conahan, to reflect on what we saw, the long queues for people queuing up to get their flu jabs at a time when we were trying to obviously support social distancing measures and we're asking the elderly and largely the infirm to queue long queues on a cold Highland morning. I'm not sure that was very helpful in terms of virus reduction. So any reflections on the wider COVID response and any particular reflection on the fact that people are having to queue at 9:30 in the morning, a queue down in the street to access their flu jabs?
Yeah, thank you. I'll maybe say a word or two about the wider COVID response, if I could, to start off with. And of course, we very much regret that anybody is inconvenienced in terms of accessing their flu jab. But on the wider COVID response, I think the committee might want to know that this is the subject of very extensive planning, guided as much by the science as by the clinical imperatives that are with us in terms of how we respond. I think members may be aware that we published earlier in this year a kind of framework for remobilisation. That framework still holds true. There are a number of objectives that we need to deliver as part of that remobilisation, and these cover not only patient safety and our ability to be able to handle both the COVID response while maintaining critical services, and that is indeed in the Scottish Government website. And maybe just before I hand over to colleagues in Highland for a more detailed comment on that, Scottish Government has commissioned and received from every health board in Scotland a detailed remobilisation plan that's currently under consideration that takes us forward to the end of this financial year in terms of the provision of services. So I'll maybe hand over to either Pam or Boyd.
Before you hand over, Mr. Conan, I saw you didn't really reference the, apart from in passing the issue around the flu jabs. I saw the Cabinet Secretary on Twitter very robustly criticising NHS Highland and saying that she was in contact with them about that issue. Do you want to say a bit more about that contact and what that?
Yes, I'm aware of the circumstances. I think this was the Invergordon situation which we were made aware of. It's very regrettable that people have had to queue for that. I know that Highland has examined its booking practices and its communication practices, so we need to learn from these things. We have 2.25 million people in Scotland to receive a flu vaccination. We will never get it right all the time, but we need to get it right most of the time. So we need to learn from these issues and ensure that that learning is rolled out across Scotland.
And was that just isolated to that one location in NHS Highland, or was that part of a wider issue that perhaps replicate in other parts of Scotland around the flu jab, Mr. Conahan?
I think with such a massive programme, we are always going to have issues of that nature at the start. I think one of the things we need to do is I think look at the way in which we message. We need to look at the way in which the national public message is put out about how people access flu jabs. We're continually refining that as we move through the cohorts, and you'll be aware that we have a sequence for delivery which looks at delivering the flu jab to those that are most in need of that at the start of this. And those are the over 65s, those who are vulnerable, and then we'll move on to the other cohorts. So the sequencing of the messaging as we move through the delivery over the course of the next 2 months will be really important. And as I said, we do need to learn from that.
So you're saying the messaging wasn't quite right this time, but we'll get it right going forward?
Well, I would like to hear from Pam about the messages that were local to Highland. She has got a little bit more on that.
What about Scotland-wide? Just on that, in terms of Scotland-wide, before I hand over to Pam Dudek, are you hopeful we can get the messaging better and right going forward because we didn't quite get it right for this cohort? Is that what you're saying?
Well, I'm hopeful that we will get the message right and appropriate. I think as I said before, we will take lessons from any part of Scotland where we don't think we've actually got it quite right. And clearly there was an issue in Highland, and that will be part of our thinking with regards to how we deliver that message across Scotland in the future.
Thank you, Mr. Conahan. Pam Dudek?
Good morning. Firstly, I would probably want to apologise again profusely for the experience that people had at the weekend. And in terms of that issue, I was actually on call at the weekend and also put out a Twitter message to apologise at the time. I think in terms of being fair to the practices who are working with our public health department to set up this very significant programme, they had considered that they had all their plans in place and had a very robust letter that went out to individuals. And that was very clear in terms of trying to manage and prevent queues, that there was a process and an appointment system. I think where we were naive was in terms of considering the wider welfare, as you've stated, as people stated on Twitter publicly, and the fact that in a rural setting, it's not always neat for people to be able to turn up at specific times for appointments. So the learning from that, and there is learning from that.
And was that isolated just to Priestley?
So much about the technical delivery of. Sorry.
Was that just an isolated incident in Priestley, or did it happen in other parts of NHS Highland?
Well, I've got a review coming in to me today that tells me what the situation has been across the NHS Highland. That's the one that's been reported to me. I haven't had any further reports, but I know as people have been trying to implement this programme, there will be further learning. Our head of primary care is on the case, is doing a review, and I've also asked them to consider going forward those wider welfare aspects, considering things like weather, like rural travel, which should be natural for us, and actions that we can take to support people who maybe can't turn up exactly on time, or maybe don't come in a car, who come by public transport. So I will have an update on that today. And we have got a range to support our GP practices who are delivering this at weekends when they've worked all week. You know, this is a big programme, as you've acknowledged, for our staff and for our population.
Thank you, Pam Dudek.
And we need to keep a very close surveillance on that.
If you can share that review, I think with all local elected members, I think that would be greatly appreciated by them. I can see one in the room that is nodding. So I think if that review can be shared, I think that would help in terms of building confidence in the programme.
Do a briefing for members.
Thank you. And just as a follow up to that, I understand there was issues at the Belford Hospital also in terms of an outbreak. You want to say a bit more about that, about what the cause of the outbreak was? Is that linked in any way to not having
Yes.
or, routine testing of staff, for example?
No, so we don't have an outbreak for a bit of staff who tested positive, and there is an increased prevalence of COVID, much in line with what we're seeing right across Highland, small class connected within the community. So we haven't got an outbreak in that area. We have got a member of staff that tested positive, and we have got small clusters.
Thank you, Pam Dudick. And then just further to that, before I hand over to Colin Beatty, who's also joining us remotely, can you tell us how many, as a result of COVID, how many procedures have been cancelled or delayed, and what assessment, if any, has been done about the long-term health impact on NHS Highland of those procedures being cancelled?
So in terms, I can't give the exact cumulative number at this point. I don't have that in front of me, but I could get that. We are monitoring weekly any cancellations for surgery, and have individual reports that come across the management team on a weekly basis. However, we have also taken some further action in remobilisation around that, as we seek to understand some of the nuances in those relating to those cancellations, and try to ensure that that's minimised. So we do have strong surveillance of it, but I don't have that cumulative number in front of me.
Thanks, Pam. The reason why I asked the question is two areas that I'm particularly concerned about. One is cancer treatment, and the other is wider procedures and the long-term comorbidities that causes. So in the last available performance report that was in Audit Scotland in March 2019, the treatment within 62 days of urgent referral was 75%, when the standard was 95%, and the average for Scotland was 81%. I would imagine that figure has dropped drastically over this period of COVID. And for the treatment time guarantee, when the standard is 100%, in March 2019, NHS Highland's performance was 54%, when the average for Scotland was 68%. Again, I would imagine that figure has fallen drastically due to COVID-19. Any reflections on that and the long-term impact on NHS Highland?
Yeah. So in terms of our, Colin may want to come in and support me in answering this question, but the 62-day is sitting now at 69%, and the 62-day cancer target is one that we're working very hard on to rectify. We understand that where that's around areas like urology and the actions that need to be taken. And we are on a trajectory of improvement there, dealing both on a clinical prioritisation approach. We are dealing with urgent cases and working our way through any backlog there. But that is dealing with some historical issues as well as having moved through COVID. The 31-day target, we are now consistently in September at 100%. In terms of that standard, we are in the right position. Overall, our recovery performance to our pre-COVID performance measure, so our March 20 measure for TTG, which was 58.2, we're at 54%. And so we are on a trajectory that we set ourselves to recover to our pre-COVID performance, with the knowledge that there are aspects in there that need a lot of work because they were not completely where they should be at that time.
Do you accept, though, that whilst the trajectory is to return to the pre-COVID levels, that your pre-COVID levels were unacceptable?
Yes, absolutely. And we are working hard, particularly around that 62-day, but all the standards through a weekly surveillance, through our performance recovery board, at improvement and redesign.
Thank you. And finally, Mr. Conaghan, just a similar reflection in terms of the number of procedures and the performance of wider NHS services. Any analysis done on the long-term health impacts that will have on Scotland?
Well, I think certainly there's quite a bit of research on COVID implications, but that's emerging. Okay, I can't say much about that just now, but we know that there are long-term implications for some patients around respiratory function and possibly neurological conditions. But I think at the heart of your question is maybe what's happening to the patients that are on waiting lists, and what's the build-up, and what is the impact for those patients. So if I can maybe just take that as where we are. But can I just give you some more detail on Highland? As part of the government's Waiting Time Improvement Plan, we saw immediately pre-COVID a significant improvement in outpatient performance for NHS Highland, and that was impressive because they also managed to keep a lid on the inpatient TPG performance while coping with all of that additional activity coming through. So there was a 30% reduction from peak over the course of the year immediately prior to COVID in NHS Highland. So we're performing exactly that we wanted on plan. And as Pam has said on cancer, the latest unpublished statistics, which is for August 2020, that will need to get verified, obviously, before they are published, shows 100% against the 31-day cancer standard. For the rest of Scotland, part of our remobilisation plan thinking is how we apply the capacity that we have in Scotland in order of clinical prioritisation. And we have adopted the Royal College of Surgeons clinical prioritisation and methodology, which is into 4 categories, P1 to P4, and I can send you some detail on that if you want. But what I see across Scotland now is that while in the previous 6 months there's been a growth in waiting lists and waiting times, I can now see the signs of recovery and that graph beginning to turn across Scotland. Now, looking forward into the course of winter, what I think we need to be planning for is 3 factors. First of all, the potential growth in COVID again. Secondly, the fact that in the health and social care sector, there is what I would call a significant drop in productivity because of social distancing, spacing, etc. That has taken some capacity out of the health service. We're alive to that and doing what we can about it by transmitting patients into digital consultations. And we also have winter to plan for. So all of those things are coming together in our thinking in terms of how we engage across all health boards and how we offer mutual support to health boards.
Thank you, Mr. Conant. I'm now going to hand over to Colin Beatty, who is joining us remotely.
Thank you, Convener. The first thing I'd like to do is note the fact that this report is almost a year old, and certainly the data in it, information in it, is certainly well over a year old. Therefore, I think there's a great deal of updating we need on this. But there are a few items in here that are worth picking up. Particularly, I may say, because I've been in this committee now for nearly 10 years, and NHS Highland has featured again and again and again. And we've sat here with the chief executives, with the board members, chair of the board, and we've received all the reassurances that everything's put in place, that everything's going to be fine. And lo and behold, a year or two later, it all crashes and burns again. Why is this time going to be different? Why is it going to be different? We've had a significant change in the governance in terms of the leadership and the board of directors and the chief executive, the chair of the board. It's a clean sweep. Why is it going to be different this time? Because this is not the first time we've had this.
Who wants to pick that up? Pam Dudek?
Pick that up initially.
Oh, sorry, Professor Robertson. Apologies, Professor Robertson.
Yeah.
Okay, I think it will be different this time because we have a new leadership in place, and that itself will not guarantee the step change that Mr. Beatty referred to that was required. But I can assure you that the team that is now in place is determined to rectify matters, and indeed we can already show improvement in our finances. We achieved a 28 million saving target last year and indeed exceeded that in 2019-20. and that was achieved as a result of having a project management office in place. And we also had some external consultants in place, which was helpful in that process. But that project management has been in mission this year, even allowing for COVID and the turbulence that has caused. We are making good progress towards our substantial savings target for this year. We will still require brokerage as agreed with the Scottish Government, but we are on track. And pre-COVID, we were very, very confident of achieving our 3-year target of breaking even next year. And I'll ask my colleague Pam Dudek to speak to that as well, and possibly Mr. Conahan as well.
Pam Dudek.
Yes, I can appreciate the question, and I guess there is an element of that has yet to be demonstrated under my leadership. However, I came in on the 20th of April as the Deputy Chief Exec for a short period, and what I've seen in terms of the robustness of the governance, the robustness of the project management approach, an embedded methodology, not just at a senior level with engagement right across the system, puts us in a very strong position to have strong surveillance of what we're doing and what we're delivering, to know where our issues are, and so we're not without issues, as everybody knows, and to make strong efforts to try and move forward confidently as we well in terms of the achievements of the last year.
Thank you. Back to Colin Beatty.
With respect, we had reports previously that outlined all the issues. And from what I see from this report, it's not changed. It's still the same issues. So why is it going to be different this time?
I'll perhaps take that to Mr. Conahan.
Is it still myself that...
I'll ask Mr. Conahan to respond to that, and then perhaps come back to Pam Dudek if she wishes.
Okay. I think at the heart of the question, it's fine having a plan, but can you actually demonstrate progress against that plan? I mean, we can describe. I think I know where this question has come from. I think in terms of us having over the past number of years in Highland described a process, but I do think we can take some comfort in a number of ways here. We've actually got, for the first time, an improving position in NHS Highland over the past 2 years. We've got an improving position in 2 ways. First of all, in terms of a financial position, and I do think the committee needs to be brought up to speed. You're absolutely right to say this is the 2018-19 audit, but I do think we need to think about what happened in 1920, and we might want to look at what the plans are for next year. All of that, if we have got enough time in the committee to examine that, will give you some degree of assurance.
Tell us, Mr. Conahan,
on a sustainable...
Tell us, Mr. Conahan, the progress that's been made financially in 1920. This is why we have you here. Tell us what that progress is.
So can I now bring Richard McCallum in, Director of Finance, and he's going to give you some facts and figures on that one.
Thank you. Mr. McCallum.
Okay, and yeah, thank you. And just to pick up on Mr. Beatty's question, I think one of the key things from our perspective is to start to see the evidence of improvement that Highland had forecast. When the Auditor General reported last year, she noted that the trajectory was for 11 million of brokerage in 2019-20, returning to financial balance by 2021-22. And in 2019-20, NHS Highland did achieve the financial trajectory that they set out. They got to the 11 million deficit that they were planning on. That was achieved through 28 million pounds of savings, as Professor Robertson has described. So the board is making the steps and is on the trajectory that the Auditor General updated on last year. And I think, as Mr. Robertson said in his opening statement, that one of the more encouraging things from a finance perspective is where we were at recurring savings of 29% in 2017-18. The board is now up at making recurring savings of around 60% each year. So there's definitely been improvements, in the financial planning and performance that we are seeing over the last year or two.
Colin Beatty.
Well, perhaps I can ask a little question about leadership, because this whole thing rotates around leadership, and that's where there's been a recurring problem in NHS Highlands. And why? I'll just ask a simple question: why is it so difficult to recruit adequate leadership, both in terms of the governance side on the board and in terms of the operational side? Why is it so difficult?
Who wants to take that question? Is that a Scotland-wide question or a specific NHS Highland?
It's specifically for NHS Highlands, because that's been evidenced over a number of years now, going back almost 10 years, that there's been repeated failures at different levels of leadership.
I think that's best answered by the chair. So, Professor Robertson.
Happy to take that one. Yes. I do think there has been an improvement in recruitment to NHS Highland in recent past. We can supply you with very detailed figures on that. But if I instance the recent recruitment round for our chief executive, our new chief executive, we attracted 15 applicants for that post, and 5 highly qualified applicants from across the UK were shortlisted for that, and Pam Dudick was a successful candidate with a strong track record in health and social care in Moray particularly. We've also more recently advertised for a director of estates and have appointed to that post, which is a new post for us, and that attracted over 50 applicants. We have currently appointed a head of comms and engagement, and again we had a very substantial list of applicants. We had to have a long list of 10 and before we reduced that to 6 for final interviews. So that I think is some indication that there is a degree of confidence building in NHS about the performance of NHS Highland and about the opportunities here to take that programme of reform, of transformation. And I should say that performance as well as culture and finance are part of that programme of transformation, which we are embarked on and making very considerable progress on. So I would like to reassure you, Mr. Beatty, that we are intent on improving the situation. And I think you will see from the current year's, well, the 2019-20 audit report, that it's a much improved picture.
Back to Colin Beatty.
Could I maybe ask the Scottish Government to comment on this leadership question that, from a historical point of view?
Mr. Conahan.
Fair question. We, in the past few years, we have established a leadership training programme called the LIFT programme. Now, that's going to take some time to work its way through. But, you know, if I was going to be self-critical of our position across Scotland, I would have to ask, have we done enough in terms of nurturing talent, making jobs attractive, and establishing a training programme for those that are at middle management level to be prepared for top management posts. So I do think and I do hope that our Project Lift programme will stand us in good stead in the future. But maybe if I could also go on, because one of the things that that we had some concerns about in Highland in some of the recent audits is about the attractiveness of Highland in terms of the confidence of people applying for clinical jobs. Okay, so we also need clinical leaders as well as management leaders. And I had a look at the 5-year history last night for as preparation for this committee. And I just think we should note that in the 5-year period up until March 2020, we did see a 21.5% increase in the number of consultants headcount in Highland, 10% increase in nursing and 12% in allied health professionals. So some things are working in Highland. We are beginning to attract clinical leaders, consultants, into Highland, and we now need to do the same in terms of supporting our middle managers for those top management jobs as well.
Yeah, that's fine on the what you might call the operational side. What about the governance side, which has been a historic problem in NHS Highlands?
Okay, can I ask Boyd to comment about the most recent non-executive position on that and how we've strengthened that in Highland? That might be more appropriate in terms of local detail.
Thank you, John. Yes, 3 new members to the board in July of last year. We are currently in the midst of our recruitment round. We'll shortly be having interviews, and there's been a very high level in these posts. There are 3 non-executive posts to be filled, and I'm confident that we will get people with expertise, including expertise in finance, to fill these places on the board going forward. So there has been a lot of activity on the governance front. Returning to Mr. Beatty's question, we've put a revised, streamlined governance structure in place with a much more effective framework and regularisation around reporting routes into the board. We've put in revised terms of reference for the governance committees. We've introduced an integrated performance report and a board assurance and risk framework, which comes to every board meeting. We had a board meeting last week, and that was the first time we had these reports before us, and it worked very well. We've also appointed a dedicated risk manager, and our governance committees have been refreshed. Each committee has been asked to appoint a vice chair. We have reinstituted a system of meetings of chairs of the subcommittees, and that is proving very effective. I have meetings on a weekly basis with our chief executive, as well as catch-ups, but we have formal weekly meetings. We also have formal weekly meetings with the chief executive, deputy chief executive, and my vice chair. So that there are many initiatives that we've taken to improve our governance structures.
One last question. One thing I noticed that is absent from this report, and I don't know if I've missed it or what, there's no mention of Rigmore Hospital. In past, that has featured very heavily in terms of concerns around its financial situation. It featured heavily in one thing which is mentioned in the report, which is the apparent overshoot on prescriptions. But it just seems to have vanished as a major item, and I just wonder: is it now deemed to be regularised? Is it now back under control? Are the costs now being contained there?
Mr. Robertson? Oh, sorry, I think Pam Dudek wanted to come in. My apologies. Pam Dudek?
Yes, in terms of Rigmore, so I suppose in terms of the whole system, we have really rigorous oversight of every part of it. And each part is interdependent on the other. So looking at one in isolation is always tricky. But what I would say about Rigmore is that in terms of those drug costs, we have seen a significant reduction in what they were. In I think 18-19, it was 3.6 million in terms of a cost pressure, and that's down to 0.9 million, and we continue to look at prescribing. Their budget is actually at the moment very stable, and is not running with the overspend that it was. However, as you'll appreciate, with COVID, we're continuing to understand the impact of COVID and what is a result of regularisation. Much of our cost improvement plan is focused on aspects of care delivery and processes that are associated with the acute hospital, and trying to, I suppose, there's a fair bit of redesign in there that will have contributed to that cost improvement. Strong work streams related to Rigmore, and it's certainly in a much more stable position. But it is something at the moment with all budgets that we are in constant surveillance of, with our weekly financial recovery board and a close eye on that.
Thank you, Pam Dudek. I believe that John Conahan wants to come in. John Conahan.
Okay. Just thank you, just a very brief comment. One of the things that we need to recognise about Rigmore is that for many, many years they operated with what I would call a deficit in their infrastructure. They did not have an effective modern day case surgery, day case procedures unit. So you can imagine that the operating model inside NHS Highland to put day cases through, let's say, a main theatre, which is the most expensive hour that you can ever buy in the healthcare system, is an inefficient and unproductive way of doing that. So we recognised that some years back by providing the funding for an elective centre that will give Highland and Rigmore a new and more modern lease of life on a sustainable basis as we move forward. But in the last few years, Scottish Government has decided to act in advance of that elective centre coming on stream by funding additional mobile day case surgery theatres. So we've altered the model of care. It's more sustainable. We're more productive now in Highland and Rigmore than we have been in the past. And of course, we need to see what happens when we eventually come out of COVID and pick up the threads of all of that again.
Thank you.
Is that you, Mr. Beatty? Sorry. I believe we have a supplementary request. Thanks, Mr. Beatty. I believe we have a supplementary question request from Willie Coffey, who also joins us remotely. So over to Mr. Coffey.
Thanks very much, Convener. It's a wee question for Professor Robertson, probably. Richard said that we'd made £28 million in savings, and I just wanted to ask you about the impact, the consequential impact on services as a result of doing that. I mean, it's very welcome that you're bringing the finances back in to target, but you can't spend, say, £28 million last year, or not this year, with no consequential effect on the service delivery. So could you just tell us how that has gone, please?
You are right, of course, to say that there are impacts in terms of savings measures such as grip and control. They're not universally popular, and no doubt they may play a part in cultural issues as well, in the interactions at the coal face, if you like, at the ward level. But generally they have been achieved with a degree of a real degree of acceptance. And I'm going to ask our Chief Executive to comment on the more particular matters.
Pam Dudek.
Thank you. I can understand the concern that's expressed there, but what I would say is that all the savings that we have taken, 63% recurring, have been developed through our cost improvement plan, our programme of work that sits there. And that is driven from the front line by our key clinical leaders, managers that are working at the front line. So the ideas for savings are generated through the PMO process from the front line, and then they are tested fairly rigorously through a process before they come to fruition and are deemed suitable to take as savings. And part of that process has got a quality assurance check that our Director of Nursing and our Medical Director sit at the helm of in terms of that quality assurance check. So the changes that have happened are quite often through potentially inefficient processes that we've had, or the ability for us to change the way in which we work, which has a consequential saving.
Thanks, Pam Dudek. Mr. Coffey, do you want to come back in?
Yeah, thanks, Anne. It's just so therefore there's there's not been really any major impact on service quality and service delivery as a result of a saving of that magnitude, then. Is that really what you're saying, Pam?
It is that the savings that have been taken have been completely checked, and as I say, it's about a 5-step check, and they don't come forward lightly, and they have clinicians and the managers at the front line at the heart of it, and as I say, is another level of quality assurance through our lead clinical governance executives.
Okay, thanks for that, Annis. Back to you.
Thank you, Willie Coffey. I'm now going to hand over to Graham Simpson.
Thanks, Convener. I just want to go back to staffing, and the report mentions unfilled vacancies. We've discussed that briefly earlier. Can I just ask how many unfilled vacancies there are at the moment in NHS Highland, and in what areas?
I'll hand over to, who wishes to take that, Pam Dudek or Professor Robertson? Who would like to take that? Pam Dudek?
I'll take that. I don't have the number of unfilled vacancies in front of me. What I do have is our vacancy rate and turnover rate. And in 2019, that was the turnover rate was sitting at 10%. That's now sitting at 7.7%. Our vacancy rate overall was 9.2%, and that's now down at 7.9%. We have had some areas. So if we talk about nursing, that's a kind of general. There's a general turnover there that looks consistent with the sort of month's notice that nurses have to give. And the year to date, so the current 1920 rate was round about 8.4% last year. That is now sitting a vacancy rate across registered nursing of 6%, which I believe is reasonably consistent with the rest of the country. In terms of our vacancy rate for medics, that's gone from an average of 11.8% to 9.5%. Now, I know in recent months, in recent weeks, we have made significant progress in some of our hard-to-fill consultant posts, and that the acute sector associate medical director has been reporting very positive progress around that.
Graham Simpson?
Right. So, in terms of number, I mean, these percentages don't mean a great deal. But in terms of numbers, can you put numbers on them? And can you say, you know, which key where are you short in consultants?
Pam Dudek?
So we've had particular areas such as ENT. We had some difficulties there, and we've made progress there. We've had some general physician vacancies that were particularly in our rural generals, and we've made some progress there. And indeed, some of these people have come with additional specialties, such as one consultant who is specialist in pain management, which is significant for us. So it's not just necessarily what they come in with as to a post, say, as a general physician in a rural general, but if they also have some additional skills, we are managing to tie that up. I'd be happy to do a brief that gives the specifics following the committee.
Graham Simpson.
Yeah, I think that would be useful. And if you can, you know, in that briefing, say, you know, where if you can break it down a bit and show us what the situation is in each part of NHS Highland, you know, that would be useful. If you don't mind, Kavina, I'll just ask another question. It's still really, it's the same issue really, and mentions in the report. I'll just read it out. It says, as part of recovery plans, a programme management office has been set up to oversee a programme of service transformation and financial recovery plans. A procurement exercise was run to appoint a permanent PMO director, and then it goes on to say that you didn't find anyone. It then goes on to say that having not found anyone, the board decided to appoint PricewaterhouseCoopers instead, and awarded them a contract which, including VAT, cost £1.2 million. How can you justify that? How can you justify spending that sort of money on consultants? You could have employed 10 PMO directors for that or more. Where's the justification for that?
Who wants to pick that? Pam Dudek or Professor Robertson? Pam Dudek?
Not sure how it works there. Yeah. So obviously I wasn't here at that time, but my understanding in terms of the requirement to bring in the capability and the capacity for us to be able to make the change, which I think has been evidenced, was the real driver for taking that decision, and that's part of the support package that was agreed to move NHS Highland forward onto a positive track. And I think in terms of the methodology that's brought and the ability to train people up and embed a different way of managing both transformation and finances, that has shown the results that were kind of doubted in that report. There was a real belief that this, well, the statements in the report that I read, the Section 22 report, was that this was perhaps unrealistic. So I think whilst I can understand the recognition of the size of that cost, in comparison with the task ahead and the improved performance and the capability of our system, I think that has shown return.
Is that contract still running?
We now have the capability in-house, and we are running that from a Highland perspective. So the contract with PwC is completed.
I've no idea what any of that means. Highland perspective. Have you
Okay.
appointed anyone?
It is now in-house. We now have it embedded within NHS Highland.
How much does that cost, NHS Highland, to do it in-house?
I don't have that figure in front of me, I'm sorry.
Okay. Is that something you can work out and send to the committee?
I'm sure we can.
Graham Timson?
Just to be clear, you're no longer employing PricewaterhouseCoopers.
Yes.
That's correct.
No, yes, we are no longer.
Right, okay. That's all.
Is that all? Mr. Conahan, would you reflect from an NHS Scotland perspective that 1.2 million cost was acceptable?
I think my reflection on 1.2 million cost is that it's, from what I understand of the PwC work, it went a lot wider than just PMO, project management skills. It was at the heart of addressing the issues on governance. It was at the heart of identifying how the system could change, as well as injecting good PMO skills. And the proof of the pudding is a little bit in the eating, is what PwC brought to Highland delivering results. We've already heard that they are. Maybe if I could take us up to the year end March 20, and this is something that is yet to come to the committee, but it's the NHS Highland final audit report for year end March 20 from Grant Thornton. And we found that while the board faced significant challenges, the board has demonstrated progress in addressing the previous findings. So I do think we need to look at this not just from the narrow perspective of PMO, but from the wider, sustainable, multi-year impact of the work of PwC in this respect.
Thank you, John Conan. I believe we have a supplementary question request from Alec Neil, who's joining us remotely. Alec Neil.
Yeah. Thank you, Convener. Just a couple of quick questions arising from this. First of all, can Pam send the committee the breakdown of the daily rate charged by these consultants? Because I used to be a consultant, and £1.1 million seems to me to be a hell of a lot of money. And secondly, can NHS Highland point out to us where the return was? I take what John Conahan says, you know, there has been progress and so on, as proof that that progress is as a result of spending 1.1 million on Price Waterhouse. So could we have those two bits of information? I realise probably aren't available just now, but I think we should be furnished with that information, because I think the public are getting fed up to the back teeth with consultants being paid film star rates, and there's no obvious benefit to that level of film star rates in the public sector, not just in the health service, but across the public sector.
Pam Dudek?
Yes, I can look into providing a briefing on that, Mr. Neil. I think the other observation that I would make from the capacity and capability that's come out of that setup is both around how we were able to restart our savings even amidst COVID, and also restart our remobilisation in a fairly swift way because of the capability that had landed within the system. So some of that's not seen as a financial return, it's how we're able to step up and do our job even within the context of a very challenging time with COVID.
Thank you, Pam. If you can give us that more detailed breakdown of what exactly was commissioned, the cost, that would be very, very helpful. I believe Professor Robertson wanted to come in. Professor Robertson?
Yes, I just wanted to say that one of the benefits of PwC was the training they provided, not just to the executive cohort within NHS Highland, and particularly those who were recruited to our internal PMO, but also I can say that at board level they provided us with training around finance and how to evaluate our finances, and that was a very productive session for the board.
Thank you. I believe John Conhan wants to come in.
Yes, thank you. I think it might also be useful, Chair, if NHS Highland could also, as well as furnishing that information on PwC, provide the committee with a copy of its remobilisation plan for the course of the next year. That would give the committee some degree of sight of what's in the future, what they're laying out in terms of plans, what do they hope to achieve, and the committee can look at that as well as look backwards in terms of where they've been.
But what we're saying, Mr. Gordon, just to clarify, is that the PwC contract has ended, so the remobilisation plan was done in-house, but the skills that were learnt the previous year from the PwC contract helped deliver the remobilisation plan. Not that the PwC was involved in the remobilisation plan, is that correct?
No, you're absolutely spot on, and I do think that if the committee can see the fruits of that work which are embedded in-house, that would be useful.
Okay. And I believe Pam Dudek wants to come back in, and then we have another supplementary question request from Colin Beatty. So, Pam Dudek.
Very quickly, just to reiterate, there was a very quick and responsible restart of the activity around both financial recovery and performance recovery as COVID, in the post-COVID period, and that was from the front line, again from our teams, and their capability and understanding process really allowed us to motor, and you'll see the fruits of that in the document.
Thank you. But as part of that breakdown, Pam Dudek, it would be helpful to see what skills are now in-house that PwC provided, and how much it costs in-house to provide that same service that PwC provided for 1.2 million. I think the committee would be very keen to see that information. Colin Beatty?
Absolutely.
Sorry, Convener, I didn't ask for a question.
Oh, my apologies. I got the wrong information from our clerk, so I apologise. I'll now hand over to a very patient Bill Bowman.
Thank you, Convener. Good morning. I want to stick on the governance area. Now, the Section 22 report highlighted areas where the board's governance arrangements needed to be developed. And in particular, it noted that the Audit Committee needed to be substantially strengthened within your structures. And the auditor also noted that at the time of producing the annual report, 102 internal audit recommendations were overdue. So, can you tell the committee first what progress has been made in implementing such recommendations? And secondly, what action has been taken to strengthen the Audit Committee? And just as a background or a reminder, during our audit evidence session in last November, the auditor advised that while the chair of the Audit Committee had a financial background, the other individuals on the committee did not have governance, risk management or financial backgrounds.
Professor Robertson.
In terms of strengthening the committee, as I indicated earlier, we are recruiting 3 members to our board, non-executive members. At present, we have stipulated that at least one of these must have a finance or audit background, and we would intend to deploy that person to the audit committee. In terms of the audit committee itself, it has now reduced the outstanding actions have been reduced from over 100 down to 14. So very solid and substantial progress has been made in addressing the backlog that they faced. And the chair of the audit committee is intent on driving that down to single figures.
Bill Bowman.
So after all this time, we're still looking for what might call qualified members to sit on the audit committee. Is that what you're saying? Because it was quite a damning comment, I thought, that the lack of governance, risk management or financial backgrounds it was a long time ago that this report was made.
Professor Robertson.
Well, we also had a recruitment round for the board last year, and one of the new members joined a highly experienced member who has experience of working in similar situations with the Atomic Energy Authority. So we have strengthened the audit committee already, and we will do so again by the end of this year when we have the new board members in place. We also put in place a risk manager. We appointed a risk manager to the board in the past year to look at our overall risk audit, and we have put a board assurance framework in place, which is one of the new initiatives that have been taken to give our board more assurance around audit at all levels of the organisation.
So if you weren't able to appoint somebody, have you done any training for the audit committee?
Professor Robertson.
Yes, we have. Yes, we have had members of the audit committee trained, and we have plans for training for the new members who will join the audit committee, and we have, as a board, had training in aspects like finance and risk management and asking challenging questions.
I looked at at your webpage to look at the audit committee minutes, and first of all I noted that under the audit committee section the last ones were from December 2019 that were posted. I then dug around and found that the audit committee then seemed to be subsumed into the papers of the main board, which I don't think necessarily gives it the right prominence that it needs. But just coming back to what you're saying about the risk assurance framework, and looking through the main papers, I saw this that came to you, I think, was it September? And I wasn't quite sure what this was. I mean, do you have a risk register that's separate from this?
Professor Robertson?
Yeah. Yes, we do have a risk register, and what's coming through to the board, through the committee structure, through the audit committee, is the high level risks for the organisation as a whole. So these are the strategic risks for the organisation.
So what are the top 3 risks for the organisation as a whole?
Professor Robertson?
I think we've been discussing many of them today. Finance is one of the.
What are the top three on your risk register?
Well, finance is a foremost risk, and the culture, our response to the Stark report is another. Our performance, which has been already discussed in this meeting, is a third risk area.
So is that the order they're in, or are you just telling me what you think the main risks are?
Professor Robertson?
These are my impressions of the overall. These are the overall areas of risk. I would have to refer you to the actual risk register itself and I'm happy to offer you that.
Could the Chief Executive tell us what the top three risks are?
Pam Dudek?
Yes, and just as Boyd said, the top three risks for us are sit around, well, workforces. That there are four that are really significant, and one is workforce. There's the culture component is clearly a big feature for us, and finance and performance. So we have work to do in all areas, and they're still considered high risks for us.
I think it would be helpful if you could actually send us
is very high.
The register so we can compare that. I would have thought COVID would have been on your risk register.
Well, COVID is within our risk, something that we are living with every day and cuts across everything we're doing. But the balance of dealing with the incident of COVID, the sustained incident of COVID, alongside how we ensure we have a sustainable, forward-looking and safe organisation still hangs around those key pillars that we've discussed.
If I might just ask one other question, I think perhaps the Chair mentioned all the different meetings that you're now having, and I know there are expressions about meetings, blinking meetings, or something like that. How do you ensure that there's good communication coming out of these meetings and they are not just meetings?
Professor Robertson?
Well, the minutes of the meetings are submitted by the Audit Committee to the board. At each board meeting, we receive a copy of the minutes of the Audit Committee, but we also have the chair of the Audit Committee at the board meetings highlighting significant issues that have been discussed at the Audit Committee. And I also sit in on meetings of the Audit Committee on a regular basis.
Convener, perhaps if we could get a copy of the risk register from...
Yep. I think the point that Mr Bowman is making is that priorities and risks are two different things. And in response to the risk questions, you know, the priorities is a separate issue. But if you can perhaps share that risk register with us, that'd be very helpful to perhaps give Mr Bowman the more information he's looking for. I believe that Pam Dudek wants to come in.
Yeah, it was just to pay tribute to the communication aspect. We are also continually at the moment looking at how we communicate both outwards and inwards. So there may be room for improvement in terms of the visibility of the information from the organisation.
Well, just maybe one final question. I mean, I know from my own experience, and subject to social distancing, does the chair or the chief executive walk the wards from time to time just to hear what's going on?
So I'll take that. Yeah, so clearly during the COVID period, that's been very difficult because for the staff to feel safe and be protected, there was a level of support from leadership and management, and also an agreement that it was better if they were allowed to get on with their job and supported appropriately, and that we didn't put people at risk by bringing additional people into frontline areas. However, post the peak that we had, the walkarounds have started. We are looking to improve on that in the coming months, but again, that will be hampered at times by the situation with COVID. We have used a lot of virtual means to try and reach the front line. And when we, for instance, were developing our own, we used the platform Teams to run workshops and to reach out to people in the front line, so that we were developing these plans together and also being able to connect with our frontline staff. I have certainly been across Rigmore and started walkabouts, and I'm connecting with Argyll and Bute next week and plan to, with as long as restrictions don't, to be as visible as possible in person with colleagues, or remotely if that's not an option.
Thank you, Pam Dudek. Professor Robertson mentioned the issue of culture and bullying, and I'm now going to turn to Alec Neil, MSP, who I believe wants to focus on this area. Alec Neil, who's joining us remotely.
Yeah. Thank you, Convener. Just before I go on to the follow-up to the Sturrock report, can I say, and I'm impressed this morning with the progress made in relation to things like finance, which is extremely important. But the most important area of performance, obviously, for a health board, which uniquely in Scotland is also the single agency for social care as well as health, are the key performance indicators for health and social care. So, and I realise we can't go into every one of those, but in terms of the top 5 or 6 key performance indicators, and Professor Robertson and Pam give us a brief overview of what progress is being made by NHS Highland in respect of these, and then can John Conahan additional perspective and compare the recent performance in these areas of NHS Highland with the performance across Scotland.
Professor Robertson.
If I can ask Pam Dudek to come in on that one.
No problem. Pam Dudek.
Yes, in terms of, so obviously in Highland we've got both the lead agency and we've got the IJB in Argyll and Bute. So those performance indicators will link to both. Some of the key ones around the MSG objectives, delayed discharges, the front door of the hospitals, the impact that unscheduled care has is a big part of those indicators. We have got quite a lot of work underway to look at how we get something more robust around delayed discharges in North Highland, because we were very successful during COVID in caring for people at home. We had obviously moved staff around to try and deal with the incident, which gave us a different capacity in different places to do different things. And of course, we're trying to learn from that. As we're looking to the winter and our winter plan, and we're working on that this month, we're looking at what aspects of that we can sustain. They've always traditionally done reasonably well in that one, but they had a slight challenge as we were coming out of the COVID era. But again, they're working hard, and we scrutinise that weekly with the community teams. The wider health and social care agenda of mental health and learning disabilities, we have, I would say, a varied picture on that, and certainly room for transformation and change in some of those areas. And the leads, both clinical practitioners, social work leads, are working together to consider what the future might look like. Some of that's in our remobilisation plan, and some of that is very much about our strategic direction as we look to the future. And obviously that will be in the context of the national frameworks that exist around mental health and learning disabilities. So there is some good, some very good work and some very good outcomes for people, but it's variable, and that's the area that I would like to focus strongly on. Obviously, I come with a background of that being one of my main focuses, and I do see room for being able to strengthen that, and room for change and redesign and modernisation.
Thanks, Pam. I believe John Conahan, Alec Neil also posed that question to yourself. So, John Conahan.
Thank you. I'll just give you some brief comments on that. I think if I can maybe just take Mr. Neil's theme of 4 or 5 key indicators. First of all, for unscheduled care, compliance with the 4-hour A&D standard, Highland in the main compared pretty favourably with the rest of Scotland. Most of our problems, as you know, in terms of being able to deliver a 4-hour A&D standard were Central Belt, but nonetheless Rigmore is big, it serves the Highlands, and I think it compares well there against the rest of Scotland. I've already made reference to the second one I was going to raise, which is outpatients, 30% reduction from peak, 14,000 on the waiting list mid-2019. Immediately before COVID, we observed NHS Highland reducing that to about 9,500 by mid-2020. Cancer performance, I think I have already referenced that their 31-day cancer performance, unpublished data for August, but it will be published shortly after validation, is 100%. You can't actually get any better than that. For the other cancer standard, which is 62 days, I would have to pick out that Highland struggle in the delivery of urological cancer services compared to the rest of Scotland. They are aware of that. It's connected with cystoscopy services. They have an action plan to do that, and we can see that backlog reducing. So those are the kind of main acute service indicators that I would cite at this stage. All in all, I think, and I can't find it, there was a reference in one of the audit reports that said that Highland compared reasonably favourably across Scotland. But of course, if you need more detail, we can pull out the stats and send it to you.
Thank you, Mr. Conahan.
Yeah,
it's interesting. Before I go back to that, it's interesting you quoted the 100% figure, which is of course very, very welcome, and you can't get better than that. So that's very welcome. But you didn't quote the 62-day figure, which is 62%, which is nowhere near good enough. So one thing is diagnosing cancer, the other thing is treating it. On the treatment of cancer, it's only 62%, meeting the target, not the 100% in terms of referral. So still work to do. Mr. Neil?
Yeah, I think that's a fair point, but generally, it seems to me that the performance is improving somewhat, particularly pre-COVID, obviously. But key to this is NHS Highland is unique in the sense that it's a single agency for health and social care in Scotland. So can I ask John, in terms of performance, and I'm talking here primarily about health outcomes and social care outcomes, in terms of performance, is there a discernible difference, positively or negatively, between the performance of NHS Highland as a single agency and the other areas, none of which are single agencies?
John Conahan?
Okay. That in itself, in terms of comparison with the rest of Scotland, is an exceptionally difficult answer to provide at this stage because of the lack of some of the comparable data that we've got across Scotland. I mean, I do think that there are issues here that you may want to go into in terms of how budgetary issues are going to be resolved in the future in terms of the delivery of social care in Scotland. There are measures that I don't have to hand that we could provide, but I think the best person maybe to answer that question with her background, coming from an integration background, is actually Pam. She worked in a different position. She now works in Highland, so she's absolutely the best person to give you some kind of answer on that one, Mr. Neil.
Okay, that'd be useful, Pam, if you could give us some indication of your perception, because I think it's an important issue going forward. If we're going to get both health and social care properly integrated, we need answers to these questions. It's now been a number of years since we've been operating both models, the Highland model and the rest of Scotland, and we really need to get the data. Policymakers need the data, audit committees need the data to know what's the best way forward. So, in being experienced on both sides of the fence, as it were, what's your take on this?
Pam Dudek?
Yes, sorry. Yes, it's been interesting for me to come into the system as it is, and with the knowledge that I've got. I think first and foremost, to maybe address data. One of the challenges that we have in many areas across Scotland, and I'm talking now from my experience as being a chief officer, is having the suite of data and the level of data from across community services to be able to prove those outcomes. So I think for most integration authorities, that is something that people are trying to develop and improve upon. Because if you think about the balance of activity that happens on a daily basis right across our communities, it's huge, and there are many factors that relate to that. So that's one thing. In terms of the models, I suppose it's like anything, it feels like there's pros and cons for both. So in terms of the structure of the governance, you have in a single agency model, you on a day-to-day basis perhaps have got a slicker governance route, and that's what I'm seeing. However, it's still fundamentally based in the premise of the worthiness of partnership working and being able to bring the right level of interest and skills from the multi-agency approach to deliver those good outcomes for people. So the fundamentals of integration are still the principles that are adhered to from what I can see in both models. And perhaps with the IGB, there is a little bit more push around the commissioning aspect because of the very nature of that additional public body. However, we're actually in the process of reviewing our scheme of integration, and I guess that's a question that's sitting there in the wings as to whether we should be operating the same model as everywhere else, or whether indeed we should pursue an improving and strengthening the model that exists. And I think both are predicated on partnership working. So a structure is a structure, it's how you work together.
Okay, that's interesting. Probably following that up is probably for another day, convener. So let me revert to my original concern, which is about the implementation of the Sturrock report. I mean, clearly the Sturrock report indicated a very, very disturbing culture operating in NHS Highland, which I don't think was entirely unique to NHS Highland, and where other people are perhaps now looking at the lessons of Sturrock. But where is NHS Highland in implementing Sturrock? Is there a better culture operating? How much further is there to go? And does it cover both the health side and the social care side? Because it seems to me if we're going to operate an integrated service, then these issues cut across both health and social care. Probably Professor Robertson.
Professor Robertson.
Probably best.
Yes, happy to take that. The response to Sturrock is a long initiative. We're on a journey. You cannot transform the culture of an organisation overnight, and it is more important that we put the right measures in place than we do it hastily. After the publication of the report last year, in May of last year, I listened personally to over 20 of the people who were involved and harmed by the experiences they had endured. I listened to their experiences, and I was really taken aback at what I heard, which corroborated what John Sturrock had revealed in his report. So I saw that listening exercise as being very important to gauge just what had happened, to understand fully what had happened. I went around our region. I went out to centres, health centres. I went out to hospitals. I went round care homes, over 30 different locations throughout our very extensive area, which covers over 40% of the landmass of Scotland. So I was taking the temperature of the organisation. I also we also engaged in staff engagement exercises throughout our region, and we had 23 such exercises, listening to our staff, hearing what they had to say, what were their views about what was reported in Sturrock and what could be done about it. We put so many measures in place. We established a culture program board, and we have appointed an external culture advisor. I was very keen that it should be somebody independent and external to the organisation, and that person is now chairing our culture program board. We put a number of measures in place, such as training for our staff, courageous conversation training, and I'm happy to say that 500 of our staff have engaged in that training program. But we've also put in place other measures for staff, such as an employee assistance program, which is run by a company, Validium. That's been active from May of this year. And in the first 3 months, it has received 16 of these were accessing counselling or other support. We also established a Speak Up Guardian service in August of this year, which is a 24-hour service, 7 days a week, just like the employee assistance program. And in August itself, there were 51 calls and 68 emails to the Guardian service. 32 cases were raised and 17 have already been closed. In addition to that, a very important part of our response has been the establishment of an independent healing process, which was a co-production between our HR department, our staff side, and importantly, the whistleblowers. And I should say that as part of the engagement process, I meet with senior executives with the whistleblowers, with a whistleblower group on a regular basis to temperature check and to sense check what we're doing. But if I return to the healing process, that is an independent process. It was launched in May. The first cases are coming through now to the Remuneration Committee, which I chair, and we've had support from the Scottish Government, extensive support from the Scottish Government with that particular programme. We've also had a review of culture in Argyll and Bute, and I suppose that speaks to the health and social care service, because that covers the area in Argyll and Bute, which is run by the IJB there. And Progressive Partnership, a company, carried out that survey for us at the very end of last year and the beginning of this year. And that was a recommendation from John Sturrock that we should undertake that piece of work, because he hadn't been able to sufficiently interact with people from Argyll. The findings of that survey corroborated John Sturrock's findings, but worryingly, they also indicated that some of these cultural behaviours were still in place. So we had to address that very quickly, and we did so by establishing another culture board in Argyll, who developed an action plan. And I'm happy to say that 30 members of staff in Argyll volunteered to join that programme board that they have locally in Argyll. So I think we've made very substantial progress in the year and a half since Sturrock reported. Some might criticise us for not doing it quickly enough, but as I said, we are wanting to take a considered view of it and to get things as right as we can, because we think this could be a template for other boards in Scotland. So we have taken. We have also had the intervention of COVID, of course, and that paused some of our activity.
I mean, that sounds very comprehensive and impressive, Boyd, and to be very much welcomed. But my final question is, how are you as a board measuring success in terms of the outcomes? Because clearly I would have thought, you know, a key measurement is the reduction in the incidence of bullying and harassment and associated activity, for example. So how's the board measuring success? I mean, all these initiatives sound very, very good indeed, but at the end of the day, are they working?
Yes, I think you're right. The metrics around that are not easy, but in the last 12 months, for instance, we have had 39 cases of bullying raised, 14 of which have been resolved. So that's one measure of what's happening at ground level. We also have a national whistleblowing champion appointed to the board by the Cabinet Secretary, and the person appointed to our board told me last week that he has had no representations from members of staff, which is just another of the measures. The statistics I gave around the employee assistance program and the Guardian service also indicate the levels of concern and issues that staff have. So these are just some of the metrics we have. There may be a need to survey staff a year on to see what is being achieved and to sense check everything that we've done.
Thank you. Thank you.
Thank you, Mr. Neil. I'll now hand over to Neil Bibby, who joins us remotely.
Thank you, Convener. I've got a couple of questions on staffing. NHS Highland has had high medical locum costs over a number of years, 15.6 million in 2018-19, 14.9 million in 2017-18, and 14.7 million in 2016-17. They also reported on that 1 million was spent on 2 locum doctors. Can I ask what the current situation is with locum costs and what action has been taken to reduce these costs?
Pam Dudek.
So the action that has been taken has been a range of things. Clearly, recruitment is the key one to try and recruit permanent staff to these posts. And as I said, that is definitely, we're experiencing a different experience in recent months with that. We had removed 14 last year of the 20 highest paid locums. And we have further to that removed a further 5 of those 20 highest paid. Now, I think when this was looked at before, there were a couple of locums of particular high cost, both of whom are not with the organisation anymore, and the one has been replaced with a substantive post, and the actions around reducing those costs have, again, where we've had to use locums, is using that on the NHS locum framework as opposed to agency. So we have an improving picture there as well, and one that we are also scrutinising fully. The issue that we have sometimes in terms of the cost and how that cost presents is the balance between the hourly rate and actually the number of hours that people are working in terms of contributing to on-call, etc. So sometimes that is reflected in the level of work that's been asked of them.
I think Mr. Bibby asked for the actual figure. Do you have the figure for Mr. Bibby?
I did have that. I'm sorry, I can't give you that figure right now. If you give me a couple of minutes, I did have that written down, and I don't have it in front of me at the moment. Sorry.
Mr. Bibby?
I was going to ask. Obviously, there has been high medical locum costs, and even if things are moving in the right direction, until we get the figure, I suspect that the figure will still be significantly high. And I just wanted to kind of press you a bit more of why there is a need to spend so much on locums, or there has been a need to spend so much on locums, and if there has been progress, you're saying there's been progress in recruitment. Why is that? Why has that happened?
Pam Dudek?
Yeah, so locums are generally engaged because we haven't got the staff to cover areas that are felt to be significant and critical in service delivery. So in those circumstances, we haven't got little choice but to do that in order to be able to deliver the service. And so that would be the main reason, and that will be as a result of either our inability, most likely because we haven't been able to recruit to a substantive post, or sickness and absence could be the other main reason that we would find ourselves with locums. Can I just ask you to repeat your second question, because I'm not sure I fully understood it, sorry.
Neil Bibby?
Well, you were suggesting there'd been some progress made in recruitment, and I was asking what was the reasons behind that.
Yeah, well, we're obviously we're trying to capture why what has changed, and this I don't have that in any kind of factual form at this point, but by asking the people that come into the post as they come into post what has attracted them to coming to Highland. We've made some thoughts around the fact that people are making different judgments about how they might live their life in the wake of COVID, because we have seen a substantial interest in posts in the Highlands, and obviously within the rural setting and the dispersed population, we definitely have, I guess, an offer where that maybe feels a safer place for people to be. But I would also like to hope that it's because some of the jobs are extremely attractive, and there is a fair degree of innovation and huge motivation amongst the clinicians that I've met to run the best services possible. So I would like to think that that's an element of it, but we will be capturing as people come into these posts what it was that attracted them, and try to understand what's different. And I suppose I could use myself as an example. So why did I go for the chief exec post of a board that looks quite troubled and has a lot of work to do? And that was by the fact that I could see some of the progress, and by speaking to people could see the motivation and the potential of this organisation.
Thanks, Pam Dudek. Did you find the figure, Pam Dudek? I'll hand over to
18.1 million.
18.1 million was the figure for 1920. That sounds higher than the figures quoted by Mr. Bibby for previous years. So you'd said in your original answer that progress had been made, but the figure's actually higher.
Yeah, so I'm going back to have a look at that figure, and I will inform the committee of it.
Okay, so
and any rationale behind it.
Okay, so it worries me that you feel progress has been made and the figure's actually higher. And also you referenced that 9 of the highest locums had been removed, your word. Do you mean that full-time NHS staff were recruited as replacements to the locums, or did you just remove the locums?
Sorry, can you say that again?
So you said the 9 most expensive locums had been removed. That was the word you used. Is that because the NHS recruited NHS staff to replace those 9, or did you just recruit 9 cheaper ones from a private locum?
So it's a mixture of recruitment and people being moved on to a different contract. But yes, there are still locums in some of those areas, but they're on an NHS locum contract as opposed to the agency, which is more expensive. So it's both.
Okay.
But no, we haven't managed to stop using
if you could share some,
completely.
if you could share some analysis on how a rise in figure is an improvement, that would be gratefully appreciated by the committee. Mr. Robertson, Professor Robertson.
I just wanted to add some local flavour. to that point about workforce, that in the Isle of Mull, for instance, where there had been a series of locums operating the 3 practices in the Isle of Mull, that has now been replaced by a permanent arrangement where we have the Oban GPs operating the practice in Mull as a unitary practice. So that's one example of how we've effected change and how we have made substantial savings in regard to locums at a GP level. In terms of recruitment as well, in Raasay, the island of Raasay, off Skye, proved to be a difficult area to recruit nursing staff to until special, with collaboration from the local community and as part of the North Skye Redesign project, a significant effort was put in to attract staff to that island, and we had the astonishing response of 30 applicants for that post. So there are good examples, I think, of ways in which we're attracting staff and which we're also containing costs.
John Conhan, I believe you wanted to come in?
Just very briefly, Convener, without extending the time, I think Boyd has covered most of what I was going to say, but I just want to maybe just put the point to the committee that we are fishing in an international pool for specialists, consultants. Over the past 5 years, we have seen an increase of around about 21.5% in the headcount. That's 35 or so additional posts that have been filled in Highland at consultant level, which is welcome. And the other thing, Convener, that might be useful for me to say is that we do need to make it attractive for applicants to come to Highland, particularly consultants at certain stages in their career. And I think that what we've done around designating Inverness as a regional cancer service, and we don't have time to do this today, but I think at some point in the future, the committee might want to have a look at what we're doing in Highland around developing new patient pathways, which are a first in Scotland, and in fact a first almost in Europe, around things like colon capsule endoscopy, which again attracts younger clinicians who want to make a name for themselves. So we are trying to do things to make it an attractive position to come and work in Highland. And last but not least, we do have an arrangement now that we want to pursue around things like shared appointments with other boards, but also travelling physicians who now do clinics, I think from Golden Jubilee for orthopaedics as an example, which avoids locum costs at source. So those are all points I'd make that might be good for the future. Convener, thank you.
John Conhan. A question for you, John Donohan, and Pam Dudek and Professor Robertson can come in. 14.9 million in 2017-18, 15.6 million in 18-19 that was quoted by Neil Bibby, and 18 plus million for 19-20. Please tell me how that's progress, because I don't understand how that can be perceived as or portrayed as progress. How is that progress?
So is this a question for me?
Yes, Mr. Conhan.
Do you think that's progress? I can't see it. Nobody can say that that's progress in a monetary sense, but let's just remember that Highland is growing its services as well. Okay, it's adding more staff. It's in the process of recruiting the staff up for its elective centre as well. Want to bring those staff on early. Okay, it also is in the process of not only replacing staff, but as I said, adding new staff. It might be useful also to understand and correlate this back to the vacancy rate. How much of the vacancy rate is driven by new positions that we're trying to fill in Highlands?
I agree, Mr. Conhan, I agree, but I believe the Cabinet Secretary when she says she wants to bring down locum costs. And if the Cabinet Secretary for Health says she wants to bring down locum costs, I don't think she would regard an increase over every year of the last 3 years as progress So do you accept that that's not progress and more work needs to be done to bring down locum costs in NHS Highland?
Listen, I cannot argue against that. I do accept it on a monetary basis, looking at 14.7 a couple of years ago, 18.1. That does not demonstrate progress, but I hope I have given you some views about how we can support Highland to be able to redress that figure in the future.
Thank you. And Pam Dudek and Professor Robertson, do you accept that's not progress and more work needs to be done to actually make progress and not just talk about progress?
Yes, absolutely. And I'll revisit the analysis.
Thank you, Pam Dudek. I'm now going to hand over to Willie Coffey.
Okay, right. Thanks again, Convener, for the opportunity to come in. I just wanted to go back to service redesign, Pam. Alec Neil led quite a number of questions there, and I won't cover them again, obviously, because of time. I do recall Audit Scotland telling us that we needed an achievable plan for service redesign and it was needed urgently. Can you just clarify, is that in place? I don't need to know what's in it. Is that in place and is it being worked through at the moment?
Who wants to take that one? Sorry, my apologies. Does Pam Dudek want to take that?
Pam?
Pam Dudek?
Yes. Am I on?
Yes, you are.
Yeah,
sorry, apologies, Pam Dudek.
Yeah.
We can hear you.
Sorry. Okay. Yes. So obviously, in terms of service redesign, we've had to rethink what the key aspects are that we take forward in the wake of our experience through COVID and the fact that we'll be in a sustained position. So redesign has been taken forward in that context, and I think the remobilisation plan that John Conahan spoke to will be an interesting document for you to look at. But I think it's fair to say that in absolutely every bit of business at the moment, there are redesign elements to our plans, whether that's in financial recovery, performance recovery, or in remobilisation. But they are connected in terms of moving forward. So we have got some very strong work streams that are progressing, and we'll continue to build on those. So there are work streams that go right across community into hospital and back again, and there are very specific work streams in some specialties.
Thanks, Pam Dudek. My apologies. Thank you, Pam Dudek. My apologies. I believe I inadvertently cut Mr. Bibby off short, and he hadn't completed his question. So my apologies. Can we go back to Neil Bibby? And I apologise profusely to my colleague, and then I'll go back to Mr. Coffey.
Thanks, Convener. I just had a follow-up, and it probably leads into the kind of service delivery of services relation to staffing. I'm aware of concerns from people I know in the Isle of Lewis. I know the Isle of Mull was mentioned by Professor Robertson, but in the Isle of Lewis, about concerns about there is new equipment in the hospital in Stornoway, but there's no staff to use it. And that's resulted in patients, some of them cancer patients, having to get on 2.5-hour ferry journeys, and others having to fly to and from Inverness. Apart from the inconvenience, apart from the physical demands and stress of having to travel such distances, I'm sure the travel costs of asking patients to travel that distance would be huge, particularly from an island. Now, I'm aware that you can't have a hospital in every part of the Highlands, but you do have one in Stornoway, and you do have one with equipment that apparently is not being used. Can I ask what you intend to do about that situation to ensure patients can get local treatment where it's possible to deliver that? And also specifically, how much are you spending on travel costs, specifically from the Isle of Lewis to Rigmore Hospital in Inverness, and how much of that has been spent on services that could actually be provided in Stornoway?
Pam Dudek?
I think Boyd was keen to take that one.
Professor Robertson?
Could I? Yes, I was just wanted to say that the hospital in Stornoway is part of the Western Isles Health Board. It's not part of our health board. Our health board is extensive enough already without adding the Western Isles, although I originate from the Western Isles myself. But so we can't really comment on the state of play in the hospital in Stornoway and the equipment there.
Okay, perhaps that's a question for the Scottish Government. Another point. Okay, thank you.
Does John Conhan want to respond to that point from a Scottish Government perspective?
I'd like to be a little bit of time to take a look at this, and I'm quite happy to drop a note back to the committee after we do some due investigation. That won't take too long, convener.
Thank you, Mr. Conhan. Back to you, Mr. Bibby.
That's all my questions. Thanks, convener.
Thank you, and my apologies to Mr. Coffey for having to interrupt and go back to Neil Bibby. Back to you, Mr. Coffey.
Right, thanks very much again, convener. I was just having a chat there, convener, about service redesign, and I think Pam was giving us an assurance that it is in place, the plan is in place, so I'll leave that issue at that one. I wonder if I could just ask, in the interest of time, convener, earlier on it was mentioned about increasing the number of digital consultations. Now, for a place like NHS Highlands, that must be really important, and one of the surprises coming out of the COVID situation is the number of digital solutions that have been appearing in this session here is one of them, isn't it? So just to ask Professor Robertson or Pam, do you see more happening by the way of digital consultation for people, and is it something that you would see as continuing with even beyond the emergency that we're in at the moment with the COVID pandemic?
Who wants to come in there, Professor Robertson or Pam Dudek?
Pam
Dudek.
Okay. Well, I suppose the short answer is absolutely. This should become part of how we do our business. I think we've had an interesting experience because NHS Highland was already fairly au fait with the use of NHS Near Me and using digital solutions, as you say, because of the rural nature of the board. However, what we have learned during COVID is that it really is something about choice with the population. So some people in our, some of our public aren't able to use Near Me because they don't have the technology and they don't believe that even if they did, that they'd have the confidence to use it. And what we're learning is that there's a proportion that can still be done by phone in terms of triage, that is safely done by phone. And for some people, that is a more convenient way in which they can have their consultation, even if Near Me is available. And then there are specialties where Near Me starts to can make a lot of sense in terms of those early day consultations. And what each area is currently doing is reviewing their experience through COVID, and as part of our remobilisation, trying to understand what the split is between telephone, Near Me and face-to-face. So we're kind of in the middle of understanding that journey, and then the next question will be, so how far can we take that? How far does that help us? Both on a health delivery context, but also in a more welfare and economic perspective in terms of people living remotely and maybe having to travel for a face-to-face is pretty inconvenient and might lose you a day's work. So we are really trying to think holistically about how we can apply this to help our population both in their healthcare, but recognising the welfare components associated with that, and indeed the wider economic and poverty agenda. So as we get through the next month or so, we'll have a better understanding of that, and we will also we're also technically looking at the capability that we require as if we need to step that up substantially. But it's an important component and has real potential.
Okay, that's good. That's a thorough response from that, Pam. Thank you very much for that. Back to you, convener.
Thank you very much, Willie Coffey. And we have Edward Mountain who's joined us on the committee today, so I'm going to hand over to Edward Mountain.
Thank you very much, Convener. I think I'm using up my lives by attending this committee twice in 2 weeks, but I thank you for allowing me to do that. If I could maybe just ask John for a point of clarification on a couple of points that he's made. John, you mentioned about cancer standard treatments. Could you just confirm, is that based on the same number of people presenting that you would think would present at doctors, or is it just the ones that turned up? Because my understanding is people are not going to doctors, therefore they can't be diagnosed because they're not seeking treatment.
I'll need to take a look at the, that's a good question. I'll need to take a look at the historical activity. And now I'll only be able to do that on published stats. I can't do that on verified, unpublished stats at this stage. But if you can allow me a little bit of time, what I'll do is I'll give you the activity data. And probably the best thing to do is to maybe give you the activity data by cancer pathway rather than lumping it all together, so you can see if there's any change in the urological cancers, the head and neck cancers, breast cancer, lung cancer, etc. So I can certainly dig that out for you. It's probably, given that these are relatively small numbers that we have, it's probably best that I do that over a time series so you can see the impact of time on that. Probably a 3-year period might suffice.
And you also mentioned, John, the elective care centre. Just remind me when that was going to be built and when it's now going to be built, and why on the basis that staff are being recruited for that now. Just explain that to me if you could.
Sorry, what was the second part of the question?
When it was supposed to be delivered, when it will be delivered, and when staff recruitment for that will be undertaken. Okay.
I'll turn to Pam for the staff recruitment. She'll have more of that. Construction for that unit was due to begin in 2019. Okay. Advanced works actually started on the 20th of July 2020. Okay. So there's at least a year's worth of delay in that project in terms of the original time plan, as far as I am informed on this. There are a couple of reasons for that. There was a change in the thinking of this. The initial design included space in the building for University of Highlands and Islands, and I think Highlands and Islands Enterprise.
John, sorry to interrupt you. I'm very happy just to leave those as bald facts. I know the reasons why the design changed and everything, and I'm sure it's not of huge interest to the committee, but it's the fact that it's not going to be delivered till the latter part of next year, and that we're talking about recruiting staff for it now. Pam, could I just say to you, welcome. It's great excitement to have a chance to talk to the 4th Chief Executive of NHS Highland in the 4 years that I've been an MSP. Hopefully some more stability in the future. So if you could just help me on that recruitment, that'd be useful.
Pam Dudek.
Okay, so thank you. And I for some time and to serve the population well. I suppose with the recruitment, there's a couple of things. There's looking at how this is going to affect our overall staffing as it sits, and who is going to be part of that elective care centre and what is not. And so there's something about our existing workforce and how that fits with it. In terms of the recruitment for going forward, I understand some recruitment is starting, but on a phased basis to support the kind of training activity that's required to be good to go. So I could, again, probably would be worth me getting a little bit more of a breakdown of what that phase 1 looks like for you, but that's the approach we're taking, and we've started that.
Okay, thank you. I mean,
I know that doesn't give you the, but I can get those for you.
Okay. Convener, if it's all right, if I can go back to the financial position. Pam, I was impressed by your statement that you were looking forward to the challenge. Well, here's the challenge as I see it. 17-18, a loss of 17.8 million. 18-19, a loss of 18 million. 19-20, a loss of 11 million. And according to the board papers in August this year, a projected loss of 75 million, 56 million which will be down to COVID, and 19 million will be down to just normal losses. Do you want to explain to me how you're going to prevent all of us being sat here for, I don't know how many years running it is, looking at NHS Highland next year and the problems of finance?
Pam Dudek.
Yeah. Okay. So I suppose in terms of the understanding of where we're at financially, we've got a really strong understanding of that. And as I said, we have frequent weekly surveillance of our financial position. So that's in itself a very transparent and helpful thing as a chief exec to be able to have everything on tap in the way that we have it. So in terms of the COVID aspect, that is an issue that is across all boards, and clearly we are working with boards and Scottish Government around the means by which we'll deal with that. If we step back from that and look at our core funding and the trajectory we're on, I believe that we are again taking every action possible to address the core gap. And I can say that at this point in the year, we have got 11.7 million risk adjusted. So what that means is 11.7 million that we are absolutely on track to deliver as part of our recovery programme, and that we have 18 million in the pipeline of opportunity. That leaves 6 million for us that we need to address. This is consistent with where we were this time last year. And it also is in the wake of losing 3 months at the beginning of the financial year where we were focused on COVID. So I guess that speaks back to the capability that I've seen in this board through the PMO approach and the training and development of not just the management team. This is held across the system, and so I think it's the action is more of that. Obviously, sense checking and understanding the ongoing impact on services as we move towards a bottom line that we hope will, through those actions, will be where it needs to be. There are risks in that, so I'm not sitting here with a naive hat on. There are risks in that, and I believe we are taking every action, including action with Highland Council, to look at how we mitigate the gap in adult social care. So this month we will have a joint monitoring committee followed up very swiftly by a project board that will be focusing specifically on social care, adult social care, but indeed also the children's side of the business, because they affect each other. So I'm again looking for a rigorous process around that, so that we prioritise together and optimise our opportunity to ensure that our budget gets back to where it needs to be.
That actually concerns me, that you're saying that you're in the same place as you were last year, and you're confident you'll get down to 6 million this year, when you didn't achieve that last year. It was just down to 11 million. I know that was your predecessor, a little bit unfair. Do you want to just talk to me a bit about the 18 million pounds in the pipeline of opportunity of savings? I don't know what that means. What does that mean? Does that mean you're not going to do...
So what?
Well, is it gapping posts? Is it reducing locums? Or is it not doing the operations? Where is that?
Pam Dudek.
So there's a whole suite of work streams, and so this sits within the methodology of the PMO, the Project Management Office, where you have ideas generated and there's a value placed upon them, and then they go through that rigorous 5-step process to either be deemed unviable or deemed viable. And so the 11.7 are those already deemed viable and in progress, and then there are additional ideas that will either be in progress of being worked up, but we haven't got the sign off on the confidence around them, or those that we will still be examining towards their viability. And that's a very live process, Edward. It's something that is being discussed with teams all the time. It's certainly a locum cost, and I'm going to go back and have a real look at the analysis around them on the back of this. Our nursing workforce, our adult social care services, and vacancy control is an aspect of that. But equally, how our infrastructure plays out is an important one as well. So in order to deliver all these services, we do that through a variety of things, such as the buildings we use, the digital capabilities. So at the moment, we're just trying to understand how we can further make those significant savings, again, protecting frontline services and trying to ensure that our quality of care is not compromised. And it isn't an easy task, but it's one I will around.
So shining the light down that pipeline of opportunity, using your analogy, that's not cutting frontline services, that's not gapping posts, and it's not reducing workforce. So just give me some particular ideas that you're looking at so I can understand them.
I'm not saying it's not. It may well change our staff profile. It may well, in some of these ideas, it may change the shape and the skill mix of staff, which is a way of redesigning and reducing cost if it's reasonable and still maintains the quality. So one big area is how we do how we run outpatients. So there's an outpatients work stream in terms of how that's deployed. And the technology comes into that work stream. So that's an example.
So how much is that going to save you? How much is that going to save you? Just a figure. Just to give me an idea. Some of the figures of the 18 million.
Okay.
I just want to get
I haven't got the breakdown of the figures in front of me, Edward, but I'm very happy to follow up. My apologies for that, but I didn't bring that level of detail in with me. So I wouldn't want to give you a figure that would be misleading or incorrect.
Okay, so just to, if I can follow up, Convener, I've got a couple more questions, if I may. Just on operations, I mean, even if you reboot and get the hospital up and running, you're down approximately a third of beds because there aren't the facilities because of the COVID restrictions. There are going to be a lot less operations carried out. How are you going to make sure that people don't wait 3 years, say, for a hip operation, if that's the current wait time?
So that is the challenge that we've got. So, and you'll know that we're using clinical prioritisation as a method to work through our waiting times. And so there's a number of actions that have been taken around mutual, what's the potential of mutual aid, what's the potential of some of the initiatives that we have managed to agree through the Access Collaborative with the Scottish Government, where we've had some, so we've had an endoscopy room brought on site. There are aspects of intervention that we've managed nationally to allow us to keep functioning. So that brings different spaces to be able to deliver some of our procedures. We're also at the moment looking at our rural general hospitals, and the kind of concept, it's not a concept because we're already started with it, but the idea of how we optimise those rural generals and the space and ability that we might have to do more procedures there, and without just that focus on Rigmore, because there is, and part of our work with PMO does allow us to look quite deep, do deep sort of examinations of what our capacity could be, providing we can staff that and can get the change in place that allows us to increase procedures across our estate, as opposed to just focusing on Rigmore.
Right. Well, I'm still at a complete loss. I'm sorry. That went completely beyond me. I don't understand how we're reducing the 3-year wait that I think may be down the line for those people on hips. There's a lot of ifs, maybe, mights, could happen, but yeah. Surely, if you're going to do it, you might have to outsource that, which may cost.
Sorry, could you say that again?
I'm saying surely if you can't supply it in Rigmore, if you can't supply it in Rigmore, you might have to outsource that, which is going to add cost, is it not?
So we are looking at mutual aid with the other boards in terms of how we might be able to do business, and we're looking at initiatives with the Scottish Government in terms of what we can access in line with other boards are getting access to external facilities who can assist us with some of our pathways. But there is a challenge there, and the challenge of COVID does create that challenge, and we will continue to try and find every which way we can to address that.
Okay, sorry. And my final question then.
But I can't give an answer on that at this point.
Okay, my final questions are, I think Colin Beatty was absolutely on the button with his questions that he raised to you at the beginning. And one of the questions was about Rigmore. In the Highlands, we've concentrated all the services into Rigmore. We seem to be doing it more and more, whether it's the Migdale Hospital reducing, or whether it's Caithness General reducing. And it's become so big that there's no way of controlling the budgets. But you say you've got it under control. None of your predecessors had. Do you feel confident that you can control the costs of Rigmore, which has become so big that there's no localised control of budget?
So at this stage, and what I said was that the budget is stable and seems to be in line. However, we are absolutely not looking at that without risk in terms of the potential of whether that is related to COVID or whether that is an actual level of pullback that's happened through our cost improvement plan. And so that is the scrutiny that I've asked for. And we will understand better what that looks like going forward. I don't think that I do not believe that it's out of control. I believe that through our performance recovery work, so what I mean by that is performance of stats of the system, and we have agreed a remobilisation plan on a level of activity that's within the budget that we have at the moment. And anything else that we need to do is being decided from a fairly robust basis and being considered within a cost envelope. So we are taking every action to control the budget, but also to try and optimise the level of service that we can deliver within the resources that we have available to us, and alongside the safety required in the wake of COVID, and that it does, as you say, have some rate limiting factors associated with it that are of risk and of worry.
I'm getting the no more questions from the convener, so maybe we could continue this offline.
I think it would make very much sense from a local perspective if Mr. Mountain and Pam Durek could continue the conversation, perhaps away from the committee. I realise that's been a very long and extensive session for everyone, so a sincere thank you for your patience and your engagement this morning, and I wish you and your team all the very best. So a thank you to John Conahan, to Richard McCallum, to Professor Boyd Robertson and to Pam Dudek, and with that thanks I now close this public session of the committee.